Thanks, Carrie. The recording has started on our side.
Thank you. Good afternoon, everyone. Hello, I'm Carrie Flockerman. I'm the Medical Science Liaison for Fertility at Next Genetics. Thank you for joining us today for our Embryo Biopsy Workshop in collaboration with Vitrolife and KAT Medical. Today we have David O'Rourke with us. David is a senior embryologist at Vitrolife based in the UK. David has a master's degree in medical molecular genetics and a postgraduate certificate in clinical embryology from the London's Women's Clinic in the UK. This will be a very interactive session today, so we really do want you to feel free to be able to ask any questions. But because we have quite a number of people that have joined us, please can we ask that you raise your hand, and then either Bradeen or myself will come to you, and then we'll call out your name and ask you to speak. This session is CPD accredited today, and we are also recording it so that we can share it with you afterwards. If you are sitting in your lab and there's more than one of you that have joined from the same PC, please will you take a register for yourselves and email that to myself or to Bradeen with your HPCSA number so that we can then still give you your CPD certificate afterwards. So thank you, David. We're really looking forward to your talk today. Please go ahead.
Awesome. Thank you very much for your introduction, and thank you for inviting me along today to talk about biopsy. Really looking forward to going into this session with everybody. Today's session has been designed very much as an introductory to time-lapse by Vitrolife. So as you said, I'm an embryologist, and I worked clinically in London for many years, performing biopsies over many embryos and many different types of circumstances. So today I'm just going to talk a little bit about when embryo biopsy should occur, and what is the best practice that we would advise at Vitrolife for that circumstance. So we're going to look initially, we're going to go backwards, and we're going to talk a little bit about embryo evaluation and the development of embryo evaluation over the last decade or so. We're going to talk about biopsy preparation and what that means in terms of getting ready to perform a biopsy safely and efficiently. We're going to look at two types of technique, flicking and laser, and what is constituted in both of those procedures. Following biopsy, we tube, where we transfer our biopsied cells to be sent to our genetic laboratory. Then we will go into some of the tips that we would recommend around the vitrification process. And finally, we are going to talk a little bit about laboratory quality control, because when we consider biopsy, we can't only just consider the technique. We must consider preparation, vitrification, and the environment in which we are performing these techniques. But before we go into these topics, I'd like to learn a little bit more about our participants and the people who are joining us today. So today we're going to try do this as much as a workshop as we possibly can, with the limitations of being in this digital kind of space. So first of all, I want to ask you guys some questions and learn a little bit about what do you do in your labs and what equipment do you use. So first of all, I'd just like to know, do you use time-lapse in your lab? If you do, please in the comment box put TL, or if you don't, put no TL. And this just helps me to focus our talk a little bit more on these areas and be able to talk about them a little bit more in terms of the biopsy procedure. So I'm going to give 30 seconds or so just to allow for you to do that. Okay, so I'm going to progress. And the final question is, if you do perform biopsy, do you perform the flicking method or do you perform the laser method? And you can simply answer by adding an F or an L into the comment box. I just want to apologize because I think I'm experiencing a little bit of a funny internet connection. So apologies if you didn't hear anything of what I said so far. Initially, there was a couple of questions, and now we're going to go into today's webinar. Okay, evaluation. So evaluation, we're talking about how are we going to assess the embryos that we have in culture. So embryo evaluation is performed to attempt to select a single embryo with the highest potential to transfer to the uterus. Traditionally, multiple embryos were transferred back to the uterus because we were able to see an increased chance of pregnancy, although this led to multiple pregnancies, which had a significant risk on both the pregnant woman, but also on the fetuses. So there's been a very direct movement in the last decade or so towards single embryo transfer. And at Vitrolife, we are providing and developing the technologies to help and aid in making the decision where we select a single embryo. Morphology assessment was our first tactic at looking at embryos. This involved a basic embryo assessment, looking at the morphology. It was a snapshot of the embryo as it developed, as we were able to retrieve dishes from incubators, look at them at the microscope, and then replace them. We soon found that there was problems with this way of assessing because there was great variations in the timings that we were performing these assessments, but also great variations in the different embryologists, even in our own lab. So the data that we were obtaining wasn't very reliable. What superseded morphology assessment was time-lapse assessment. This involves taking multiple images over a number of stacks through the embryo and putting those images together to form a kinetic morphological development of the embryo. And this way we're able to look at the development steps, the timings in which they occur, and allow this to aid in our decision making of a single embryo to transfer. We were able to apply algorithms to this data, to use technology to decipher the timings and the events in which these occur. And the latest technology uses time-lapse to estimate the time of the morphokinetic events, so we can more accurately determine if an embryo is going to be viable or not. What's limiting about these assessments is that they're observational assessments. So we don't physically get a chance to assess the embryo and its components. Where genetic testing, it allows us to do that physical test and have confidence in the results that we're getting. We all know as embryologists that when performing biopsies, we're never 100% certain that we're going to get a normal embryo result back. Even really good quality in terms of morphology assessments can be aneuploid or unbalanced chromosomes. So it's important that we go the extra step to check the chromosomes and physically assess the embryos to aid in our selection. We know that aneuploidy or imbalanced chromosomes increases as a female ages. And we know that these embryos are totally indistinguishable from each other. We've tried to develop algorithms to differentiate these embryos, but we still accurately aren't able to do it. So genetic testing is still the gold standard in embryo selection, and we see it in the results. So in order to perform an invasive test, we need an embryologist to perform a biopsy. As we can see from this small video here, a biopsy involves taking a small amount of cells away from the trophectoderm cells of a blastocyst in this case. These cells are then representation of the entire genetic makeup of the embryo. We use lasers that are connected to micromanipulators to aid in this process. We have biopsy and holding pipettes, which allow us to perform both the flicking and the laser techniques. And these are tailored for biopsy at different stages. We also use pH buffered solutions such as GMOPS Plus or GGAMIs, or in the instance of day 3 biopsy, GPGD solutions, to help us aid in this biopsy technique. At Vitrolife, we also have the solutions that we provide to genetic laboratories to allow them to detect the aneuploidy in embryos accurately. We're all trying to detect and figure out the euploid embryos because we know that these embryos have the highest chance of implantation and pregnancy. So it's important that we can perform these techniques accurately so we can prioritize ultimately getting our patients to pregnancy and live birth quicker. So if we evaluate our stages that we went through in terms of selecting these single embryos, we started with morphology assessment, which is a single snapshot of embryos. We soon figured out that this was a flawed mechanism. Time-lapse greatly increased our ability to learn what was happening with the embryos. And with the advent of algorithms and AI, it helped with differentiating embryos with higher quality to embryos with lower quality and lower chance of implantation and pregnancy. As I said, these assessments are very observational and they're not a physical test of the embryo. And that's why genetic testing is a really key element in our evaluation of embryos. At Vitrolife, we have those solutions to help accurately detect aneuploidies. So when preparing for a biopsy, there's many aspects that we need to consider. First of all, being the biopsy pipette that we choose to use. There are two main types of biopsy pipette, a fluted design or a standard design. A fluted design is done to create a minimal invasive technique where the sides of the biopsy pipette don't damage the trophectoderm cells. It could be used more appropriately for pulling and laser techniques. But standard design, where there's a sharp edge, can be used very efficiently for a flicking technique. That sharp inner rim allows for a really clean biopsy of the cells. Size matters with these biopsy pipettes, and that all depends on when are you going to perform the biopsy. If it's day 3, the biopsy needs to be a little bit larger, as the blastomeres are considerably bigger at that point. When performing trophectoderm biopsy, we would consider using a small size up to 30 microliters. But we don't want that to be too big or too small, because we will lose control of our biopsy technique. Biopsy pipettes is a very personal thing, and I would advise anybody to try a couple of different types and find which size and which design is most appropriate to them and the way that they like to perform the biopsy. So this is a stage that you would go through normal training. On the picture on the left, we can see the difference down a microscope from the minimal invasive design on the left, on the right, and the sharp on the left. Quite difficult to decipher, but through many biopsies in the Vitrolife lab, we're able to determine the ability for a fluted design to be a lot softer on performing trophectoderm biopsies with laser. The dishes that we provide at Vitrolife are specifically designed to support and facilitate the different procedures along with biopsy. They are critically, the bottom of the dish is in direct contact with the heated stage, which means that there's a very thermo-efficient transfer of heat from the bottom through the plastic to the media and into our embryos, minimizing the amount of stress caused by the difference in heat. There's many dishes that you can see here that are of all applicable stages, but during biopsy, what we would use is a 5-well dish for our vitrification, but use our ICSI dish for the biopsy procedure. This dish allows for a wide space, so the biopsy pipettes can be easily maneuvered around the dish and the biopsy can occur efficiently. As I said, the bottom of the Vitrolife dishes are in direct contact with the heated stage. On the picture on the right, we can see the points at which the embryos are placed in the dish. There's no yellow points, so there's no cold areas on these dishes. So there's minimal amount of stress when using this dish. In my experience working in clinic, going from one dish to another, they can have different heights, causing different temperatures in the media and causing stress to these embryos in biopsy or in many other different types of techniques that we perform in the lab. This is one simple, easy way that we can minimize the stress and increase our success rates. Now, a number of you have said that you use time-lapse. I think it's a really key part of the biopsy procedure, as it allows you to look at the embryos through their developmental process and select embryos when they're ready for biopsy. So if they are either fully expanded, if that's when you choose to do your biopsy, or when the trophectoderm has herniated sufficiently from the zona. The other advantage of using the Vitrolife time-lapse system is that it's an extremely modern incubator. So it's extremely efficient with the heat transfer to the dishes, but it's also extremely efficient with the gas recycling, as the CO2 gas is recycled back into the chamber in which the embryos are present, creating a really stable environment for the embryos, but also saving a significant amount of gas. So the dishes associated with the time-lapse system also have individual locations for each embryo to be placed. This means that embryos can be tracked from whence they are injected or whence they're placed in this dish until they are ready for biopsy. These videos are really key when the results are returned from the genetic laboratory, because you can go back and assess the embryo development and make sure that you're picking the strongest embryo if you get a number of euploid embryo results back. Again, it's all about assessing and picking that single embryo for transfer to give your patient the highest chance of pregnancy in that cycle. So with the consumables, the key elements to this are holding and biopsy pipettes. As I said, this is a very personal feeling that each embryologist will have, and it's up to you to determine through your training process what you feel is most appropriate and what you feel is most appropriate for the technique in which you are planning to do your biopsy. Biopsy dishes need to be wide and they need to be IVF safe. You've put significant amount of work into this point to get your embryos to a blastocyst stage. So it's important that we look after the embryos through the biopsy procedure. In addition, these dishes are connected to the bottom of the heated stage, allowing for a very efficient heat transfer from your inverted microscope heated stage through to your dish, minimizing the stress to these embryos. Time-lapse allows you to select the embryo when it's an optimum time to perform the biopsy. And it also allows for the traceability of embryos right from the start, all the way through embryo culture. So those videos can be used as selection aids once you get your results back from the testing laboratory. Okay, so let's get into the topic of which we are here to discuss, and that's embryo biopsy. So embryo biopsy is performed either on day 3 or on day 5. A day 3 biopsy involves using embryos which have an unknown developmental potential because it's a very early stage of the embryo development. It's a relatively high cost because you're ultimately always going to biopsy more embryos than you would on day 5, and you're going to biopsy more embryos that are going to make it to day 5. So there's a potential loss of time there. You taking away a significant amount of biomass, because even at day 3, a single cell will be a considerable percentage of the biomass of the embryo. You're only going to take a single copy of DNA away, which makes it difficult to amplify and quality control those results that you take. And we know that the results from day 3 are lower when considered to day 5 in terms of pregnancy rates per transfer. Now, if we look at day 5 biopsies, we know that these embryos are viable because they're blastocysts. So they've had the ability to get to that blastocyst stage. It could be considered a lower cost because ultimately there's going to be less embryos to biopsy, saving time for your embryologists. Even if you take 3 to 5 cells away, it's going to be a less in terms of the percentage biomass when compared to day 3. And you have the advantage of having 3 to 5 copies of DNA, making your results a lot more consistent. When we are preparing to do the biopsy, excuse me, is there a question?
No, David, you can carry on. I think it was just somebody that we were admitting. Sorry.
Oh, perfect. Let's go. Just checking. Okay, thank you. So, as I was saying, when we're getting ready to do our biopsy and we have our embryos that are at an expanded blastocyst stage, we need to protect ourselves and protect the environment in which we're going into. One way we do that is clothing. So we need to wear face coverings, face masks, gloves, and the appropriate clothing to make sure there isn't any cross-contamination from ourselves to these dishes. We always make sure that there is 2 persons to fulfill the witnessing and to fulfill the full length of procedures from the selection of embryo to the biopsy procedure, tubing, and subsequent vitrification of these embryos. Having 2 people there signing it off is a really key quality control element to this because tracking these embryos is of absolute importance. We will always work inside a laminar flow cabinet, again, to minimize the possibility of any cross-contamination that might occur. We use a simple stereo microscope with a heated stage to observe our embryos and our biopsied cells. We perform the biopsy on an inverted microscope with a number of different optics, which has a heated stage, micromanipulators, and mostly is placed on an anti-vibration table. But this can be optional based on where your clinic is and where your lab is situated inside your clinic. The micromanipulators must have a positive and negative pressure control so we can perform this procedure, and a laser such as an Octax needs to be connected to the inverted microscope to aid in both the flicking and the pulling technique. Assisted hatching of our embryos prior to doing our biopsy is almost always required. The timing in which you do this assisted hatching is really key. And this again comes down to the technique that you decide to use within your clinic. There are 3 accepted times of when you can assisted hatch or make a hole in the zona. If you do it on day 3, it's very easy to perform because there's always a space between your cells and your zona. But it can be problematic when the embryos develop because you don't have any control on is the inner cell mass going to herniate, and if the inner cell mass does herniate, that could cause problems for whereabouts you're going to perform your biopsy. Day 4, you have a little bit more control, and if you wait until the embryo starts to cavitate you can start to see where the inner cell mass may form, and that can inform where you perform that assisted hatching or where you perform that hole in the zona to aid in your biopsy. Finally, which is my preferred, is performing the assisted hatching on day 5 as you're doing the procedure. So if you put pressure on the zona and slightly collapse the zona, the trophectoderm cells will start to come away from the zona, which allows you some space to make a small hole in the zona. Personally, I feel that this provides optimum control, as we can make sure that the hole in the zona is a sufficient distance away from the inner cell mass that we're not affecting those cells. Now, both of assisted hatching needs to be performed for both techniques. That is for flicking and for laser. And if we consider these two techniques in a little bit more context, flicking being a mechanical way of biopsying cells, it's a little bit higher risk. It's technically quite easy and quick. You're able to biopsy 3 to 5 cells, so you get 3 to 5 copies of DNA. And this technique can be performed with or without the zona. The laser biopsy, which is a laser assisted, which involves pulling the embryo and using the laser, is a little bit lower risk, but it's quite technically challenging. So it does require a highly skilled embryologist with a lot of training to make sure that they're competent and confident with doing this procedure with human embryos. Again, we get 3 to 5 copies of DNA. And technically it can be performed with or without the zona, although I would only ever perform a laser biopsy with the zona, and I would perform the flicking biopsy with embryos that had fully herniated from their zona. And that is the way that I used to differentiate these two techniques. So first of all, we're going to look at flicking. Now, on the next slide, I have a video, but first of all, I wanted to run through the steps that are performed in this technique. So starting at A, we can see that a significant amount of the embryo is herniated from the zona, but we can also see the biopsy pipette just coming in here. Now, from this observation, we're unable to see where the inner cell mass is, but we might be able to guess that it's there, or it's still inside the embryo, hopefully. On the next picture, we see the biopsy starting to engage and starting to create negative pressure on the trophectoderm cells. A small laser shot is hit between the two cells, causing these herniated trophectoderm cells to collapse, allowing more cells to enter into the biopsy pipette, which can be seen through picture D and E. Once sufficient cells have entered into the biopsy pipette, then a negative pressure is put on the holding and biopsy pipette. And the two pipettes are aligned with, in this circumstance, the biopsy pipette on top of the holding pipette. When they're perfectly aligned, the holding pipette is pushed upwards, putting pressure on the biopsy pipette. Secondly, the biopsy pipette is pulled down, creating a flicking motion of the pipette, where you are left with the embryo and your small amount of biopsied cells. So the face of both of these pipettes are grind in front of each other, which cuts the biopsied cells apart. So it's a nice, quick and easy process. Now, let's talk through the technique as it occurs. So, looking at the picture here, we can see the holding pipette. We've got our zona. We can see that more than 50% of this embryo is currently herniated, and in this circumstance, the inner cell mass is present outside the zona. So the embryologist is going to perform the biopsy as far away from these cells as possible in this bottom section. We can see the biopsy pipette here, which is currently coming into the right plane to perform the biopsy. So they're just getting the biopsy into the plane, starting to engage on the trophectoderm cells. They're going to start adding a small amount of negative pressure while also using the laser to collapse the trophectoderm cells and this biopsy. So you can see the pipette has slipped off this embryo, and this occurs when we don't have, or we're not able to come in direct contact with the trophectoderm cells. So this is one of the problems that occurs when the inner cell mass is herniated and it's in a position that we need to alter the way we do our biopsy. So this is one of the reasons why we always look to do the assisted hatching as late as possible so we can control where that inner cell mass is. So the embryologist is creating negative pressure. He's going to do a laser shot now. There we go. So we can see the embryo collapsing very quickly, and that negative pressure allowing for about 3 to 5 cells of the trophectoderm to go into the biopsy pipette. Excuse me. Okay. Now, sufficient amount of cells have gone into the biopsy pipette. So now the holding pipette has gone into a negative pressure. And as we saw from the pictures before, the embryologist decided to put the biopsy pipette on top of the holding pipette. In this circumstance, the embryologist is deciding to go underneath. It completely comes down to a personal choice on whichever is easier for the embryologist to perform. This is an extremely key element in terms of the flicking technique, because the biopsy pipette and the holding pipette are both round. So in order to find that point, this is the time where you should take extra care to make sure that both of these pipettes are lined up so that flicking is performed really accurately and quickly. We can see the embryologist testing. So when you see the biopsy pipette slightly falling off, that's the embryologist thinking they're on the center, testing it and seeing that the pipette is falling away to the side, which indicates that the pipette is not directly in the middle of the holding pipette. So when the embryologist is happy, you'll see the holding pipette coming down, putting pressure on the biopsy pipette, and then the opposite, moving the biopsy pipette forward. Creating that flicking motion. And we can see it happening very quickly, but putting sufficient amount of pressure on the biopsy pipette to allow for that flicking to occur, to create a really clean biopsy. It's It's hard to determine from this picture how many cells are there, but it looks like there's 5 to 6. And we can see the embryo is perfectly safe. The embryos have been biopsied away, and this embryo is now ready to go for vitrification, and cells are ready to go for tubing. So let's consider the laser technique now, and let's go through the steps that are normally associated with this technique. So if we start with A, we can see again, this is an embryo which is herniated more than 50%. And similarly to the last embryo, the inner cell mass is present in these herniated cells. First of all, the embryologists engage with the trophectoderm cells. A single pulse is provided, and to this point we're doing exactly the same. And then with the laser technique, the 2 biopsy pipettes are pulled apart. So they pull the embryo and they stretch the cells, so you're able to see the junctions in between the cells where the laser should be applied. This can only occur when sufficient amount of cells have entered into the biopsy pipette. A number of pulses, 3 to 5, should be sufficient to biopsy a single embryo. You can see in this circumstances that there's complete control from start to end, and the embryo never leaves the safe point of the holding pipette. Now, let's consider the video. Now, this is much the same. The advantage of this embryo over the previous is that the inner cell mass is relatively close to where the zona hatching occurred. So we're able to treat this embryo as if the inner cell mass is still inside the embryo. Similar to the last one, the embryo is at least 50%, if not more, herniated from the zona. And the trophectoderm cells are very clear, and this biopsy is going to occur very quickly. So when we consider how long you would take to biopsy an embryo, it's generally accepted that it shouldn't take longer than 2 minutes per embryo. This is just to minimize the amount of time that your dish is outside the incubator. We know that the more and more time an embryo spends outside the incubator, it is causing stress. Now, the biopsy pipette has engaged these trophectoderm cells directly away from the holding pipette. This aids in the pulling process once the trophectoderm cells have been collapsed and once sufficient cells have entered into the biopsy pipette. So a laser pulse is going to be applied. We can see the pulling of these pipettes is already occurring. Now you can see as soon as the laser shot is applied to the embryo, it starts to collapse, and that's directly related to the pulling, because you're putting pressure on the cells and you're pulling these cells apart. They're going to collapse really quickly. It also means that there's a lot more negative pressure coming from your holding pipette and your biopsy pipette in this technique when compared to the flicking technique. So in this, we can see that the cells are entering into the biopsy pipette quite quickly. Again, you have this extra negative pressure, but you're always in control when you're doing so. Now, you can start to see the laser being applied and they're looking for specific junctions between the cells. So we don't cut through an entire cell and have free DNA around the place, that we're very efficient, and we're just looking for the areas that are combining those cells. And in this circumstance, it looked like it was 3 shots to perform this biopsy. So positive pressure can be now applied to the biopsy pipette, releasing this embryo. The embryo is ready to go to vitrification. The biopsied cells can be seen coming out of the biopsy pipette, ready for tubing. We can see in this circumstance that there's a few more cells than when compared to the flicking, say somewhere between 6 to 7, maybe even 8 cells. So as you're aware, glass can be very sticky, and sometimes you can have a little bit of trouble with getting your biopsied cells out. If this occurs, you can give your biopsy pipette a very gentle flick, which will dislodge the cells and allow them to float into the media, ready for tubing. Okay. Now, after we perform a biopsy and we have our embryo, which is safe and ready for vitrification, we need to go through a process of tubing. And this is a process which is often not thought about in as much details as it should. It's a really key part of this process, and sufficient amount of time and thought should go into it. We've just spent a huge amount of effort and time and money to get our embryos fertilized, cultured, biopsied, and now tubing them is a really key aspect. So I would like to show you, excuse me, I'd like to show you a video which was provided by my colleague. Tubing is one of these techniques which is quite difficult to explain in this circumstance. So I'm going to allow my colleague to run through this. He was kindly made this video in the lab to run through this tubing process. Now, I must say that the volume on the video is a little bit low, so please turn up your speakers just for the purposes of this, and this video is just under 5 minutes long.
In this short video, we're going to show you what you do with the biopsied cells, how you get them into the PCR tubes to send to your genetics lab. So what we'll be showing you is the consumables you need, the media you need, and the techniques to reliably get those cells inside the tube so you get a result from your genetics provider. So here's the equipment and disposables we need for cell tubing. Now your genetics provider will provide a rack of PCR tubes, which you have to pre-label with your patient ID and of course also the individual identity of each embryo. Next to those, you'll also have a blank control, which again will be the same embryo number, patient ID. The genetics provider should also provide some kind of wash buffer. It may be a lysis buffer, it may be a straight PVP wash, and you'll be setting up drops of that to rinse the cells before they're placed into PCR tubes. A standard Petri dish is fine for setting up the wash drops. And of course, you'd use an individually wrapped pipette tip to set up each set of wash drops for each individual embryo. And again, to move the cells, you would use a fine tip, like a stripping tip. And again, you'd want to use one individual tip per embryo that you're going to move the cells for. This is just to ensure that you don't get trapped cells from one embryo being pushed into the PCR tube of another. Just to make sure that you don't get any cross-contamination. So the cell tubing, the first thing you want to do is prepare your rinse drops with the buffer provided by the genetics provider. You may want to just set up one drop to rinse the embryos in, or you may set up two, which is quite good to maybe get rid of any oil from the transfer pipette. We ensure there's no oil transferred into the PCR tube. Now, the genetics provider will probably want you to provide a blank to test the media you dispense. So here we'll be just taking a couple of microliters of the wash solution from the drop and placing it in a PCR tube. This PCR tube is numbered with the same number as the embryo of the cells you're going to move into the wash drop in a few minutes. At this point, we're going to move the cells that we've biopsied from one of our embryos into the wash drop. At this point, if you've got several embryos cells within the same dish, you probably call a witness to ensure that you're picking the tracing of the embryo is accurate from biopsy dish to wash dish to the actual PCR tube. So we're just picking up the cells and putting them into in this case, our first wash drop. We gently aspirate the cells up and then put them into the first wash drop. A few swipes at the end of the pipette takes off any oil that might be on the tip of the pipette. And we can move them to the second wash drop. Again, rinse the pipette, and we're ready to place it into the PCR tube. So again, at this point, your witness should be identifying the ID and the embryo number on your PCR tube. And what we're going to do is pick up the cells in 1 or 2 microliters of liquid of the wash buffer, place it into the PCR tube, and this really should be done. You should visualize the cells actually going into the tube. Most genetics providers will actually ask you to say whether or not you've seen the cells go into the tube. They seal the tube and place it back in the PCR rack.
Okay, I think that was a good representation of how tubing can occur. And as I said, I don't believe a lot of people really give it the respect that it deserves. It's a really key part of the biopsy technique, a really key element that we visualize those cells safely going into our tubes. So our genetic testing laboratory has the material to accurately test the embryos in which we've biopsied. So when we consider the biopsy procedure, we need our clothing, we need 2 people, and we need the proper equipment in the terms of a laminar flow hood and micro manipulators, so we can safely and accurately perform the biopsy. With the laser technique, we need to use, or with the flicking technique, we need to use the laser to provide some early shots in order to collapse the embryo, and then using the biopsy pipettes, we flick one off another, tearing some cells essentially away from the embryo. The laser technique, using a static laser, where we pull the embryo apart, we look for the junctions in which the cells are connected, and we use the laser to cut the embryo away. The tubing is a highly accurate procedure that should be performed with 2 people, and it should be performed slowly with all of the clothing on to make sure that there's no cross-contamination. So we're providing the highest possible quality samples to our testing laboratory so we can get the highest possible results from these tests. Now, due to the movement of biopsy on day 5, we've also taken a big step in terms of our cryopreservation and the technology in which we use. So traditionally, we would use a slow freezing technique, but more recently we've moved to vitrification, which we have seen to be a lot more reliable. And the embryos that are thawed from vitrification are a lot more viable, and the data shows that they lead to higher pregnancy rates. So vitrification of day 5 embryos is almost essential to give sufficient time for the genetic testing laboratory to accurately test the embryos, and also for the patient to take some time to wait for the embryo transfer, and to give the embryologist and doctors time to assess the results and accurately determine which embryo has the highest potential to transfer. At Vitrolife, we use medias which are designed for specific stages to perform the vitrification. We use ethylene glycol and propanol because we know that these are less toxic to embryos, yet as effective. And as non-permeating cryoprotectants, we use sucrose and glycerol as they're very efficient at removing water from these embryos. So when thawing or worming these cells, we need to rehydrate the cells. So we use cryoprotectants in the form of sucrose, which slowly allows the water to be reintroduced back into the cells. At Vitrolife, the vitrification procedure is performed at 37 Celsius, which allows for a very efficient transfer of cryoprotectant from outside the cells to inside the cells. This also means that the procedure is quicker. So from a traditional equilibration stage of a cryopreservation of a day 5 embryo, it's somewhere in the region of 10 to 15 minutes, where with Vitrolife this is considerably shorter, where it's down to 2 minutes. So if you perform a lot of vitrification, then you have a significant time saver. Also, within the Vitrolife system, we use a tool called the Rapid Eye to hold our embryos in place and keep them in place when they go into long-term storage. The Rapid Eye is extremely easy to use and is a lot easier when compared to the other tools based on personal experience, and also based on teaching people how to use this, an extremely quick and easy tool to use. The Vitrolife system also has a closed system, which reduces any chance of potential contamination. The elements that are associated with this technique is the smart box, which you can see down at the bottom, which helps with control of the straws, as there's magnets placed into the smart box which are directly connected to the straws in which the Rapid Eyes are placed. So it's a completely closed system, so the embryos never come in direct contact with the liquid nitrogen. When we consider vitrification for our biopsied cells, we need to consider cross-contamination. And at this point, making sure that DNA from one embryo doesn't get cross-contaminated with DNA from another embryo. One of the ways in which we do that is by first cleaning these embryos off, so having a step before they go into vitrification, and then tracking these embryos. So first of all, using the VIT1 solution in a separate dish. So for example, with the dish on the left, we can place one embryo in each one of these wells, so we're able to track and keep account of the embryos that we've biopsied with a witness on our shoulder. With the second dish that you can see on the right hand side, we have the VIT2 solution and VIT3 solution. The VIT2 solution is the equilibration step, and the VIT3 is the vitrification step. The embryos can be subsequently put through these steps and vitrified. So, as I said, at Vitrolife we have a number of a number of cryopreservation solutions which account for the different stages. So, for example, if you were doing day 3 biopsy and freeze, there's a cleavage stage vitrification set, and there's a blastocyst vitrification set. More recently, Vitrolife have brought out the Rapid Vit Omni, which is a vitrification and warming solution for all stages. But it's important to note that it's always a compromise using one solution for all stages, because oocytes are considerably different than blastocysts. So having medias that are appropriate for these cell stages is key to getting the best outcome and the best results. So that was a quick snapshot of how you can change your cryopreservation to account for doing biopsies and account for tracking embryos post-biopsy. I'd like to take the last couple of slides just to talk a little bit more generally about laboratory monitoring and control. There's so many possible routes to contamination. It's key that we first of all minimize that chance of occurring by wearing the appropriate clothing, which we've touched upon, but also using the right equipment, such as laminar flow with HEPA filters, to minimize any dust or anything that can occur to cause stress to the embryos. We know that this equipment can drift, and we've seen it in all of our laboratories, that incubators that can move into faulty stages maybe, and they go outside of their running parameters. And if there isn't any monitoring system keeping track of these embryos, this can occur without the embryology team knowing. So by having sensors within our incubators keeping track of CO2 and O2, we're able to determine that we can have the most optimum environment for pH, and we can keep a really close eye on the data that we're taking from our incubators, making sure that they're performing at the highest possible, that they're performing as they're meant to. So our embryos have the highest possible chance of viability and chance of pregnancy. So if any of these parameters were to drift in your incubator, a system could pick this up and send text messages to members of your laboratory, so you're able to deal with this problem as quickly as possible. Again, minimizing the time that the embryos spend outside that optimum point. We also want to monitor ambient environments. We know that seasonal temperatures can have an effect in the lab. Winter temperatures can cool the lab, causing cooling effects to the dishes that we use on heated stages. So by monitoring, we can control these things and account for them. We also want to look at VOCs that are present in the laboratory and minimize the VOCs that we bring in. Something as simple as a cardboard box can give off VOCs in the lab, and this can have an effect. Other more severe things that people have found in their labs, such as paints and plastics, give off VOCs, which are embryotoxic. Vitrolife has a product called Lock and Guard, which is used to monitor all of these different parameters, including liquid nitrogen, making sure that you've got that extra level of protection in the lab, that extra level of quality control to make sure that those embryos are being looked after and that they're in that optimum environment or optimum range for development. So the sensors that currently exist within the suite are CO2 sensors, oxygen sensors, temperature, pH, humidity, and ambient monitors that will look at temperature, humidity, and VOCs. Liquid nitrogen sensors also exist, and all of this information is gathered and can be easily accessible, so you can determine potentially even the procedures that you perform in your lab. When is the optimum time to do your embryo transfers, and how much are you opening incubators? All of this information is really key to getting the best system and ultimately getting your best embryos for your patients that can be either biopsied and frozen. Okay, so thank you everybody for listening. So today was very much an introduction into biopsy, looking very briefly at the two techniques that are kind of widely used, laser and pulling, being used about 90 to 95% of the time, and flicking used about 5% of the time, I'd say. So we've also looked at what are the old monitoring techniques that were used, and what was the flaws around those monitoring techniques. We talked about the consumables associated with biopsy, how personal a biopsy pipette is to the embryologist, but also to the technique, and the time that should be spent in training and getting a feel for these different types of pipettes. We've talked about the quality control that can be helped in terms of dishes. If we use dishes that are IVF specific, we know that they're safe for embryos, and we know that they're in direct contact with the heated stage, creating a very thermo-efficient environment for the embryos. We looked at how time-lapse can aid in biopsy by determining, first of all, when you can perform the biopsy, but then after you get the results, helping you to differentiate between two embryos that come back with a euploid status. We went into the techniques, and we looked at those two videos and briefly looked at how that biopsy should occur. We looked at tubing and how important tubing is to the entire process and to getting robust results. And we looked at cryopreservation. As we all move towards day 5 biopsy, cryopreservation is a really key element to it. It's pretty much the cornerstone to modern embryology, and all the techniques that we perform are all anchored towards vitrification. And finally, we took a very overview of some of the sensors that can be used to make sure that the laboratory environment is optimized and controlled for embryology. So thank you everybody for joining, and thank you for listening. If there's any questions, now is potentially the time to do so.
Thank you so much, David, for your time and for joining us today. But before we go, we just want to wait and see if anybody does have questions. We didn't really receive many questions in the chat box, so if anybody would like to ask, you're more than welcome to unmute yourself and you can just ask in that way, or you can also type it in the chat box if you prefer. We'll just wait a few seconds and see if there are any. I don't see anyone typing, so then we'll just say thank you very much to everyone for joining us today. Should you have any questions after this, you're more than welcome to contact us at Next Genetics. You're welcome to contact me directly if you would like, and I will always pass on your question to David, and then we'll get back to you with anything you need. Of course, you can also contact KAT Medical about anything, any of the supporting things we chatted about today in terms of all of the media and all of the consumables, but I can also pass those queries on for you directly to Robin if that's easier. So thank you so much, David, and thanks everyone for joining us.
Thank you for having me, and thanks again for everybody for joining. Any questions, please reach out.
Thank you. Bye-bye, everybody.